Good afternoon, everybody. Um, Welcome to this UNA USA Global Engagement Online Series event. Our topic today is birth equity. My name is Beverly Issa, and I am a UNA Global Goals Ambassador for SDG 3 Health. I have a master's degree in public health, and I am a global health advocate both in Los Angeles, California, and abroad with my outreach work with malaria and HIV/AIDS eradication in West Africa. And I would like to now introduce my co-host and co-ambassador for SDG 3, Nikita Vikas.
Hi, everyone. My name is Nikita. I'm also a Global Goals Ambassador for SDG 3, Good Health and Wellbeing. I graduated this year with degrees in neuroscience and economics from the University of Texas at Dallas. And during undergrad, I conducted research on molecular genetics and population health data science and did internships at the U.S. Department of Health and Human Services and the White House Council of Economic Advisors on healthcare policy. And I hope to continue working in that realm and in addressing healthcare disparities in the future.
Wonderful. Thank you so much, Nikita. And I would now like to introduce our two panel speakers for this program. First, we have Dr. Jillian Seeley, the Chief of Staff at Power to Decide, an organization that advocates for the rights of all young women, that no matter who they are, where they are, or what their economic status might be, have the power to decide if, when, and under what circumstances to get pregnant and to have a child. We also have Dr. Joia Crear-Perry, the founder and president of the Birth Equity Collaborative. NBEC creates solutions that optimize Black maternal and infant health through training, policy advocacy, research, and community-centered collaboration. So I guess we can jump in now into what is birth equity. Birth equity is essentially equality of maternal health care and education while ensuring a safe and healthy birth experience for all women, regardless of racial and socioeconomic conditions. This includes postnatal care, which focuses on healthy breastfeeding practices, screening for postpartum depression, monitoring the newborn's growth and overall well-being status of the mother and child. Birth equity is a needed conversation today in our society because American women die in childbirth at a rate higher than any other developed country in this world. Black women are more than 3 times likely to have a maternal death than other racial groups in the United States. Now, Nikita will talk about the disparities we are now facing in health equity.
When striving to reach birth equity, it's critical to understand disparities. And maternal morbidity and mortality occur among Black women, women with low incomes, and women in rural areas at much higher rates. As Beverly mentioned, maternal mortality rates for Black women were around 40.8 deaths per 100,000 people, more than 3 times higher than the rate of 12.7 deaths per 100,000 for white women between 2007 and 2016. The rate for American Indian Alaska Native women were also much higher at 20.7 deaths per 100,000. And these minority women are also more likely to have births with risk factors that increase the likelihood of infant mortality or long-term negative consequences. And these disparities were only exacerbated by the COVID-19 pandemic, as people of color were bearing a disproportionate burden of COVID cases. And these discrepancies are caused by a multitude of reasons, including socioeconomic status and social determinants of health, institutional racism in healthcare, and social service delivery. Urgent action is critical to address these systemic biases, and addressing these disparities has been a focus in both local and national initiatives, mostly centering around raising awareness of and addressing biased decision-making, along with addressing Medicaid improvements for maternal and healthcare coverage. And now we're going to hear from our first speaker, Dr. Seeley, on a little bit more on healthcare disparities and how to address them.
Hi, everyone. So good afternoon. First, let me say I'm honored to be speaking to you all today about a topic that is critical to the work that I do, but it's also important to me because I'm a Black woman, I'm a mother, an advocate, and a public health professional. And I'll also say that I enjoy tremendously working alongside a woman that I admire so much for her tireless efforts in this area, Dr. Joia, who will be following me because she just has a wealth of experience and really is passionate about this work. So I'm honored to be sharing this stage with her. And then finally, I'll just say I also have a special place for UNA USA because I was a member many, many years ago in the Tampa Bay chapter. So just wanted to bring that full circle in terms of the work that you guys are doing and that I'm very familiar with. So thanks to both Nikita and Beverly for providing, much needed information on birth equity. And I'm hoping that, with the information and the discussion that we have today, that you can see why this issue is indeed very critical. By way of background, I am the Chief of Staff at Power to Decide, as was mentioned, and it's the campaign to prevent unplanned pregnancy. And here, we believe that when people have the power to decide if, when, and under what circumstances to get pregnant and to have a child, they have the opportunities to achieve the futures that they want, right? For nearly 25 years of Power to Decide's existence, we have been a national leader in improving access to sexual and reproductive health information, both at the individual level, but also at the systems level. And I'd say to go even further, not only do we believe that people should determine for themselves if, when, and under what circumstances to get pregnant and to have a child, but also to parent the children that they do have in a safe, healthy, and thriving environment. So I think that definitely is key. Today, I know we're going to be talking about birth equity, the reasons for the disparities in maternal morbidity and mortality, especially among women of color, women living in rural areas, and low-income women. And specifically, I've been asked to talk about contraceptive deserts and the impact of that on birth equity. So first, why don't we go ahead and define what a contraceptive desert, what contraceptive deserts are. So contraceptive deserts is defined as counties where the number of health centers offering the full range of contraceptive methods is not enough to meet the needs of a county's number of women eligible for public funded contraception. So the needs are defined as at least one health center for every 1,000 women in need of publicly funded contraception. And I don't know if your audience is familiar or even knows, but more than 19 million US women with low incomes live in contraceptive deserts. And again, these are counties in which there's no reasonable access to a health center offering the full range of contraceptive methods. And I let that sit there for a minute because, living in a country where, we are seen as the leader in the world, we also have some of the worst health outcomes, as well as access issues as it relates to sexual and reproductive health. It's worth noting as I talk about contraceptive deserts and access barriers, that nearly all women, almost 99% of women, regardless of race, ethnicity, political or religious affiliation, have used birth control at some point in their lives. And given that we know that access and availability are paramount to ensuring contraceptive equity. And so we further understand that when you're talking about health equity, that you're not just talking about it in the moment, but that you're talking about it across a lifespan, and that it should also include birth equity. And so to just delve a little bit deeper in terms of contraceptive deserts, I listed out what contraceptive deserts are, but also there's some contributing factors, right, to this as well. So when we look at rural populations and people with low incomes, you can only imagine that if you're a woman or a person living in a rural community, you often face barriers getting to a clinic to be able to access sexual and reproductive health, including contraception, abortion, prenatal care, postnatal care. You face barriers in terms of what those long drives look like, right? especially if there's no public transportation to get to the nearest clinic, to offer that full range of whether it's contraception or reproductive health. In addition to distances and transportation, we do know that people with low incomes face barriers, including childcare costs, because oftentimes these facilities are not equipped to accept children. And so we know that childcare costs are also some things that have to be included, as well as a lot of times unpaid time off from work, which can add up if you have to do more than one appointment. So you're going to a doctor, you need to come back, for instance, if if there's a form of contraception that needs a second visit. And so those costs do add up. And I think it was also mentioned that for Black and brown people and low income people that face challenges, that a lot of this is informed by the social determinants of health, right? And social determinants of health are conditions in the environment where we live, we learn, we work, we play, we worship, that have an impact on our quality of life outcomes and risks. And so I highlight contraceptive deserts and the access challenges to lift up how limiting access to to comprehensive reproductive health can contribute to poor maternal health outcomes. It's no coincidence that maternal mortality and abortion restrictions are both on the rise in the United States. In fact, between 2010 and 2015, states that enacted more abortion restrictions, and they've done that during the last 5 years than compared to any other time since Roe versus Wade. But we've also seen that the maternal mortality rate has grown by 136% between 1990 and 2013, 136%. And so restrictions on women's health care, including abortion, can have devastating impacts on a woman's health. There was an analysis done by the Center of American Progress, again, that showed that states that had more abortion restrictions had higher rates of maternal and infant mortality. And moreover, research has shown that more abortion restrictions a state has, the worse women and children's health outcomes are in that state as well. The Center for Reproductive Rights, they conducted a study that created a state-level scoring system, and it included measures of abortion restrictions, policies that supported women and children's well-being, women and children's health outcomes, and the social determinants of health. And the study used indicators such as parental involvement in, waiting periods for abortion, as well as expanded Medicaid, and the existence of a maternal mortality review board. But what was interesting is that the study found an inverse relationship between abortion restrictions and women and children's health outcomes, as well as a number of evidence-based policies passed to support women and children's well-being. So for instance, South Carolina, for example, has 14 abortion restrictions, and also some of the worst outcomes for women's health in the country, including maternal mortality rates that have risen over 300%. We've seen a surge of new abortion bans and clinic closures that has, again, impacted America's maternal mortality rates. And while none of the abortion bans have gone full effect yet, they come after state legislatures have spent years enacting strict regulations on clinics. And by doing that, this has resulted in defunding family planning programs. And we do know that in many communities where there's a clinic that provides contraception, that is not the only service that is available to people in that community. It could be, perhaps looking at cervical cancer, providing abortions, providing reproductive health services. And so when those clinics are closed, those have devastating impacts. I know I'm throwing a lot of statistics at you, but really the goal is to highlight how Black mothers and birthing people, in fact, experience the highest rate of maternal morbidity, which are serious complications from birth, as well as mortality deaths of any racial or ethnic group. Black mothers and birthing people are still 3 to 4 times as likely to die from a pregnancy or birth-related cause, and twice as likely to suffer a maternal morbidity, such as hemorrhage or infection, than those in any other racial group. And these statistics are really, really concerning because as in public health, there are fundamental barometers that we use. And so when you look at maternal morbidity and mortality metrics, that's how we kind of determine the health and well-being of a community, of a region, of a state, of a country. And so it's really concerning to us that the rates are the way they are. And then I wanted to just also highlight that of note, even when you consider for age or income or educational level, even health insurance status, we know, to be honest, that we need to acknowledge and to be intentional about the solutions that we're proposing that get at explicit and implicit bias, structural racism. Instead of just focusing on race, or in addition to just focusing on the impacts as it relates to racial and ethnic disparities, we really need to also call out some of the contributing factors like racism and structural racism that also have impacted this. Because we know that even when you look at a Black mother who has a college education, she's still twice as likely to die when compared to her white counterpart who has a high school education. So clearly we can see that huge disparities are there, even when you look at the education of the mother. We know that implicit bias and racism are known to exist, not just in the healthcare system, but also at the individual provider level as well. And so we need to be truthful and to call that out. And also to understand that with a patriarchy approach to women's reproductive health, again, it has detrimental effects, especially as we've seen and we've heard accounts, both seen in studies, but also heard from women as well, that not listening to women about their needs as it relates to their health and their well-being and their pregnancy, not listening to their concerns, not supporting a shared decision-making model has also had detrimental effects as well. And so we need to be, again, very clear on what we're wanting to achieve as we talk about improving maternal mortality and morbidity. I think it's also interesting, just in some of the research that we have done here at Power to Decide, in looking at highest maternal deaths in states, again, that have restrictions on abortion or just restrictive reproductive health policies to begin with. So when you look at Alabama, Arkansas, Kentucky, or Oklahoma, we definitely know that these are contraceptive deserts, again, where publicly funded contraception, the full range of contraception is not available. So for instance, when we look at Alabama, over 311,000 women in need of publicly funded contraception live in contraceptive deserts. In Alabama, there were 7 facilities providing abortion in 2017. 5 of those were clinics. And these numbers represent no change in clinics from 2014, when there were 9 abortion providing facilities overall, of which 5 were clinics. And so as clinics start to close, as again, we see restrictive policies as it relates not just to abortion, but reproductive health in general, again, it has a devastating impact on the way that a person is able to access comprehensive reproductive health care, which again contributes to poor maternal outcomes also. And then I'll just mention, when we're talking about improving policies, when we're talking about calling out things like structural racism, that we also need to center Black mothers, Black and Brown people as it relates to their reproductive health, and looking at maternal morbidity and mortality. So for instance, when we're looking at talking about reproductive well-being, we want to make sure that the patient is at the center, that they're seen and heard, right? That when they come into a facility, from the time, before the time that they become pregnant, that they're respected for their reproductive health decisions, that they have the autonomy to make the decisions that are right for themselves and their families. I think there's nothing worse than giving someone resonant and accurate information, but then not letting them make the decision that works for them and their families. We also know that we need a system of support. So we don't just need healthcare access, we need quality healthcare, right? And we need quality healthcare that is accessible and affordable. And we need less restrictive policies on reproductive health, so that women can access the services that they need to make sure that they are healthy, as well as their families as well, when we're talking about this. And I think, we're talking specifically about the United States, but, when you look outside of the United States as well, there is also, you're seeing where there are restrictions on abortion, so where unsafe abortions happen, that it does account for maternal deaths, or where there's not access to healthcare or adequate or quality healthcare, that also raises the level of maternal morbidity and mortality that we're seeing. So my takeaway and my advocacy is that we really need to, it's not going to be a one size fits all. We definitely, again, need to look at the policy side, but also as practitioners to really center, people of color and birthing people as it relates to, maternal and morbidity and mortality, having forums like this, right, to educate others on, what they need to do and the autonomy that they need to have over their bodies. I will say that, I did not grow up in this country. I grew up in the Caribbean. And one of the things that always resonated with me when I was much younger is when I was a child, my grandmother always used to say, getting pregnant is like having one foot in the grave. And I just thought it was just so morbid. And when I got a little bit older, I would say to my mother, I just don't understand what that means. And she would say, like, when you're pregnant and you're having a child, like, people don't understand all the complications that can come along with that. If you don't have, quality healthcare, if you're not listened to, if your provider, goes off and does what he feels is better without that shared decision making. And hearing, my grandmother, who was wiser beyond her years, understanding now as a public health advocate, what that means when you say, like, pregnancy is not something that we should take lightly. And it doesn't start when that person, that birthing person, comes before their physician and says, I am pregnant, what do I need to do? It starts much earlier than that, right? Because we want to make sure that people are their best healthy selves as they plan to have their families or not. And so I'll leave that with you to just say that, again, I appreciate the opportunity to be a part of this discussion. I think it's extremely important. And let's really, lift up the causes, the root causes of maternal morbidity and mortality, including racism, structural racism, patriarchy, and let's find sustainable solutions to address it.
Thank you so much, Dr. Seeley. I really appreciated your insight just now. And I actually love that you touched upon the social determinants of health and that being a factor. I have a question for you. What can we do at a community-based level to kind of combat, as far as the social aspect of birth equity? How can we empower each other on a community level to get better care?
Yeah, I think it starts with, really advocating at the community level for policies that support, especially Black and Brown birthing people around, birth equity, right? I think I often say that, I think, look, federal policy is federal policy, but I also think, at the local, the regional, and the state level, there's a lot of power, right, in numbers. And I think it works with those local activists lifting up, the disparities that we're seeing in our community. And again, I think you touched on the social determinants of health. And I think in the public health arena, we know what that means, right? But for others, there's not necessarily, for others, social determinants of health don't mean as much, right? Because if you're a woman in Alabama, Mississippi, and you don't have access to care, right? The social determinants of health mean nothing. And so being able to lift that up, I think, to be honest, I think we really need to have honest conversations, and we're seeing that happen. And as I mentioned, I know Joia, you weren't on, but I always point to you as being just an advocate for really calling out racism, right? And calling out, we're hearing about it a lot more within the past year, and I don't have to tell you the reasons why, because of the events that have happened. But for folks like Joia, who have tirelessly been talking about this and beating the drumbeat on, people not being heard, people being looked at, not just implicit bias of the healthcare system, but just explicitly being biased and racist towards especially people of color. And I think we also need to dismantle myths about the Black birthing experience, especially as it relates to things like pain, right? Like, oh, Black women are able to sustain more pain than others, and not being listened to in terms of what they need for themselves to feel whole. I think that needs to happen. And we've seen many folks who have had babies and knew that like something wasn't right and have been dismissed to their detriment and to their deaths. And so I think lifting all these things up in a community, there's power in numbers, is going to be one of the ways that we can address it.
I love that. Thank you so much for your insight and for also kind of highlighting our next speaker. I would like to introduce our next speaker on this panel, Dr. Joia Crear-Perry, the founder and president of the National Birth Equity Collaborative. Dr. Perry is a proud recipient of the Congressional Black Caucus Healthcare Heroes Award and the Maternal Health Task Force at Harvard University Global Visionary Award for commitment to advancing women's health. She will be speaking with us today about birth equity through the lens of emerging shift to telehealth. Welcome, Dr. Perry.
Thank y'all so much for having me. I'm so excited to be here, and I am always honored to be on a stage with Dr. Seeley, who's a brilliant researcher and fighter and advocate in this space, and just honored to be here with our colleagues here at the UN Foundation and across the world. And I love that the title of this is Birth Equity for All Women, because that's really the focus of our work at the National Birth Equity Collaborative, and that's what we've been trying to fight for. And I just hope that we can help to share with you how we got to that journey, what made us choose even this language, right? And what that means, and how you operationalize birth equity in your work and what you do around the world. And I am technically not savvy, so Katrina's going to help me to not look crazy. Can you push the next slide, please? I think it's Katrina. Okay, great. Thank you. So we just recently redid our mission. So I'm going to read it with you all, because it's important that I keep saying it out loud and reading every word, because it's important for me, because we've expanded. We're about 6 years old. And we originally started similar to the Power to Decide with a focus that was not our current focus is, right? So our orientation 6 years ago was on Black infant mortality. That's it. And our original mission was to improve birth outcomes for Black infants. And the truth is, when you work on doing that, you have to undo racism, patriarchy, and the other things that Dr. Seeley mentioned. And so as we've been on this journey of seeing how to improve Black infant mortality, it expanded our understanding of what our role is in this space, how we can use our privilege. I'm an OBGYN, so I come with a lot of privilege. I come with privilege of being an American from the United States. And so all of that, using that to really push global work. So we are now creating global solutions to optimize Black maternal, and because it's important that we're not just saying people can survive something. Like our original mission was increase outcomes and improve. No, we want people to have optimal health, right? And so that's for maternal, infant, and sexual. It's not just having a baby. We also want pleasure. We want joy. We want to have access to sex ed, access to freedom around your sex work, right? So all of those things are part of our work. And then, as Dr. Seeley just mentioned, reproductive well-being. So we use our reproductive organs don't have to just be in the context of birthing. And how do we think about our well-being as a full picture, not just physical well-being, but emotional, financial, all the other underpinnings around power that fit into that. And so that's why we work really hard to shift systems and culture through training, research, technical assistance, policy, advocacy, and really community-centered collaboration. That's the core of our work. We really don't do anything alone. Everything we do starts with a community organization that's leading that work, and we're following their lead. We're listening to them to tell us what are the needs of that community. We have a lot of core values, but the one I want to lift up today is power, sisterhood, because on this panel, the people here between SEMA and the folks, y'all are my sisters. We wouldn't be able to do this work if you did not exist. So I'm very grateful and thank you. All right, next slide, please. So birth equity, when we started 6 years ago, there was not a definition for birth equity. There were definitions for health equity, for equity in general. So we looked at our mission and our vision and our values and said, well, how do we have these definitions around health equity and equity in general meet the needs of birth equity, right? So a lot of the equity definitions talk about equity as a place. We're gonna get to this place where all the resources are equal and everybody can hold hands and sing Kumbaya. We fix the problem, we can check it off and dance to the sunset. Well, we all recognize in our current political environment that you get 5 or 6 steps forward, you might get 10 steps backwards, right? So like this magical place is gonna happen. We have to never worry about it again. We also know that the same people who are hoarding power and wealth today are teaching their grandchildren how to hoard power and wealth, right? So it's not so much that we're gonna get to this space. Ooh, my internet, can y'all hear me still? Said it was Wednesday. Okay, great. So it's not so much that we're going to get to this space where we don't have to think about this anymore, right? We're going to have to teach our grandchildren to fight for justice and joy. So that means we have to put the assurances in place, not educating people on what they should be doing, not blaming and shaming people, but really our job is to put the assurances. So that's policies big P, like in the United States, health for all, or a policy little p, right? Like if you are a clinical provider, are your hours meeting the needs of the patients that you see? Are you ensuring that it's in a community setting that the people look like and come from the communities that you're serving, right? So that matters. That's an assurance for the conditions, right? So our job is to create the conditions for optimal births so that all people, not just who you think is important, not just who you value, not just who you see, not just who you know, all people have the ability that can thrive. So that means we have to be willing, with our power and our privilege, to address both racial and social inequities in a sustained effort. So that means a 2-year grant is not going to fix this. A 5-year grant is not going to fix this. It's going to take prolonged, sustained work by all of us. Next slide, please. And so back in 2005, I was here in New Orleans, and I was the director of maternal and child health. So y'all know what was happening in New Orleans in 2005, right? The president flew by from Air Force One and waved at us. The World Health Organization actually came here to the city, came to the hotel, because all this building, 80% of the city had flooded. And they were talking about this idea that it wasn't your genes or your choices that cause health disparities, but this thing called social determinants of health. Things like having safe and affordable housing, quality education, food, job security, right? That those things determine your health. Push it again, please, Katrina. And that those things cause you to have psychosocial stress and unhealthy behavior. So when you don't have a social safety net and connection, you're gonna have stress and you're gonna exhibit unhealthy behaviors. Push it one more time. And that's where you'll get a disparity in the distribution of disease, illness, and well-being. This is so important. So when we say women are more likely to to die from heart attacks and not be seen and not be heard, right? It's not because there's some biological, like we don't have some hormone for our heart. If we don't have access to childcare, if we don't have access to support the things that we need, we're accumulating harm. Same thing when you see a disparity in the distribution for Black people. It's not some gene for Blackness, and that's not we have different kidneys or different lungs or different pelvises, but these social determinants can make the distribution of the disease, illness, and well-being off. But what you see, the top of my slide is still empty. Because although many of you on this call, hopefully, can quote the social determinants of health, you know what that means. We've talking about it now since 2006 when WHO created that definition. we don't talk about where they come from, right? So we don't talk about how did this happen? I've always lived in Black communities, not because it's tribal, and I just see Black people and say, oh, I want to live there, although I do like Black people, right? But there's redlining, there's neighborhood covenants, there were federal laws and policies that said this is where you must live, right? So these social determinants didn't just come from thin air. They were created, they were manufactured through the assurances of not having well-being for all people. Push it again, please, Katrina. And so that's really going above the social determinants. Like, how did we get here? Push it one more time. And that's because we have a power and wealth imbalance. Push it again. And push it one more time. And those are things like our labor markets, our housing policy, globalization. This is so important when you think about this work in UN and UNFPA and UN Foundation, right? This globalization, deregulation, our social networks, our tax policies. The US's tax policies impact all of us and our ability to thrive in this social determinants. And, you know, I'll give you an example in my own city of New Orleans. So 80% of the city flooded. So, you know, nothing like a disaster for folks to come in and make some money. Disaster capitalism is real. So folks came in and tore down low-income housing and built mixed-income housing. So they made money off destruction, money off of building the new facilities. It's called mixed income. So that means you have to have at least less than 10% of the people who live in the housing be low income. You get a tax break. So then you only have to live there for 10 years. So what do you think happened in 2015? All of the poor people were kicked out of the mixed income housing. So they made money over and over and over again. So you displace poor people who now have thousands of people who don't have homes, but that tax policy, the powerful people who make money off of that choice to say you get a tax break for destroying people's homes and not allowing for them to have a place to live. None of us on this call would choose that as a policy. We would say that is a power and wealth imbalance that is disproportionately harming poor and low income and under-resourced folks. And how do we ensure that they are housed and we don't create more homelessness through our tax policy, right? So in the US, they have three main root causes. Push it again, please, Katrina. And push it again. And they are racism, classism, and gender oppression. Now you could add some more. I mean, in my own state of Louisiana, Lord knows you could add religious fundamentalism. That's huge here and around the world. You could add, in another context, casteism. You could add tribalism, right? You can add any of those root causes, the things that categorize people, that harms us, that holds us into boxes, into systems, and create structures and policies based upon those. They're not just beliefs and morals and ideas. They become actual policy that then is placed upon our bodies, right? Push it one more time. So it's important for us to understand the social determinants of health and to work hard to make sure that when you're doing granting or doing work, that you ensure that your patients or your clients or the people you serve, or the communities you work with, have fresh fruits and vegetables. That is critical that you provide that. But if you're not actually making for a way for them to make their own fresh fruits and vegetables, you are not undoing the root cause of racism, classism, and gender oppression. We don't want you to just give us a fish. We want to be able to catch our own fish. That's going to make us be able to see justice and joy in the future and birth equity. Next slide, please. So you have to talk about the history of reproductive injustice because we have exported that from the United States around the world. So I'm an OBGYN. The father of modern gynecology in the United States is J. Marion Sims, and he's pictured at the top there. I mean, he created instruments that we still use today, a Sims retractor. He was a plantation doctor. So the transatlantic slave trade had ended in the United States. It became illegal, but slavery was still legal. So in order to continue the economic engine of this country, which was Black women's uteruses to produce children that were then utilized for work, they needed to make sure that when people had babies, they could keep making more and more babies. So a plantation doctor started gynecology, and he would do surgeries on at least 3 Black women who were enslaved, Lucy, Betsy, and Anarcha, without anesthesia, although anesthesia was available at the time. And he would cut fistulas and sew them, and cut them and sew them in rooms surrounded by other white men who were also practicing to become OBGYNs. That's the founding of my field, decimating and practicing on Black women's bodies, and then saying and writing in textbooks that we did not feel pain because we could survive these surgeries. And they couldn't get a white woman to participate in the surgeries, as if being enslaved was a missing piece that they were not aware of, right? So really that underlying and underpinning of devaluing Black bodies, Black women birthing people's bodies, using us for exploitation, for experimentation, continues today. When you think about the hysterectomies and the surgeries that were done at the border on immigrant women in the United States this past year without their permission, this belief that you can just do anything to poor people, to marginalized people, to immigrants, has a long and deep history of injustice. We also know that in my own university, Tulane, where I trained, there was a doctor named Dr. Cartwright who created an illness called drapetomania. If a slave looked you in the eye, you could whip him harder. If he tried to escape, you can cut off a toe. So it's an illness for freedom called drapetomania. And if a Black person wanted to be free, they must be crazy, right? So you can then harm, you could put the treatment was harming us. We also know this history, and this is so important, especially as you do your work around the world around reproductive bodily autonomy and freedom, understanding that it comes from a legacy and history of eugenics. It comes out of this idea that certain of stratified reproduction, that some countries and some people and some human beings are deserving of birthing and others are not. So this manipulation through family planning, the history even of our United States family planning was started by Nixon in 1970. It was his anti-poverty strategy to put family planning clinics in Black and brown communities. I would argue that if 50 years ago, Nixon had said free college in Black and brown communities, we would have less poverty. But this idea that we're gonna get to freedom and to decrease climate change through the uteruses of Black and brown and marginalized communities, it comes from a history and a legacy of eugenics and population control. And it's just not, it's not true factually. There's no scientific basis for it. So how do we really undo and unlearn these things and make different choices about well-being, around bodily autonomy, around freedom, investing in and trusting people of color around the world? Next slide, please. So when we looked at the data around Black maternal mortality, we were so nervous about how it was going to be framed. Because when you see that the UN called us out, said, United States, we see you. We see that Black people are dying at 3 to 4 times the rate of their white counterparts. What are you gonna do about it? You are one of the wealthiest nations in the world. You spend way more money on everybody else on healthcare. Why are Black and brown women dying? We knew what the US was gonna say, but they always say, blame and shame us. Well, they're so fat, those Black women, they don't listen. They're so obese, their BMIs are so high, they don't go to the doctor. So we had to get the data to dispel these myths, this bias that's baked into our system, that's reflexive for people that automatically, they're not married. That's always, if we just get married, everything we'd be all saved. I'm still looking for that husband. Maybe there'll be husband number 3 that's gonna save me, I don't know. Anyway, so when we actually looked at the data, it turns out that Black mothers who are college educated fare worse than women of all races when it comes to maternal health. The CDC just replicated this. A Black woman who has an advanced degree is 5 times more likely to die in childbirth than a white woman with an advanced degree, right? Obese women of all races have better birth outcomes than Black women who are of normal weight. So we're trying to do our little crunchies. Obesity is the #1 bias in the United States. People come in for a toothache and we tell them we need to get their stomach stapled, right? So they're just so fat. Turns out even when we're skinny, ask Serena Williams, we die, right? Black women who live in the wealthiest neighborhoods do worse than white, Hispanic, and Asian mothers in the poor. So we moved to the gated community. Racism is like, I see you, sis, where you going? No, ma'am, come on back over here, right? And this last one is really hard for my fellow OBGYN colleagues and I to absorb, because we love to say, if you just came to the doctor, we could fix all of your problems. We are the center of the universe. Make those 12 appointments and you will survive. The data says we're wrong. Black women who initiate prenatal care in the first trimester still have higher rates of infant mortality than non-Hispanic white women with late or no prenatal care. That's not saying that prenatal care is not important, but it's just not as important as being white, right? It's not as protective as being white. And this also doesn't say that we shouldn't go to school, that we shouldn't try to exercise, that we shouldn't try to live in nice houses, or that we shouldn't get prenatal care. In fact, we do all of these things. We currently do all of these. This is our entire public health strategy for all people around the world. Just go to school, get an education, buck up, bootstrap, you'll be all right. Turns out when we do all those things, we still die. So at some point, someone has to invest in undoing the harms of racism, white supremacy, and patriarchy on our bodies, because we're doing our part. There's a lot of people who are funded to tell us, to educate us, to tell us how to raise our children, to do all these things. Who's funding the undoing of the harm of racism, classism, and gender oppression inside the systems that are harming us despite how we show up? Next slide, please. Next slide, please, Katrina. So I was honored. I've been able to present now with you guys a couple of times, and I could say I've testified in city council here in New Orleans. That was like my first, oop, go back one. I testified here in city council here in New Orleans. I've testified in Baton Rouge at the State House. I've even testified in front of Congress. But going to the UN is humbling, deeply humbling as a Black woman in the United States, because we don't recognize that the United States does not have a human rights framework. We don't operationalize a human rights framework. We make everybody fight for civil rights. Black folks were looking for the right to vote, LGBTQ community trying to get married, women, white women trying to get access to paid leave and equal pay. Like we're all looking for these issues just to be seen as fully human. When you have a human rights framework, when you operationalize it, you believe that people just by virtue of their birth have value. What would be super exciting, what would make America actually the exceptionalism place that we claim to be, is if we show that a diverse nation, diverse in ethnicity and race and gender, that we can actually believe that all people are valuable, right? Most of the countries that have this as a standard, they're very monolithic. How can we show that diversity, you can invest in human rights for all, even in a diverse place where everybody doesn't look the same, speak the same language, or even have the same moral codes? Next slide, please. So we know through the Sustainable Development Goal number 3 that good health and well-being, that word well-being is really important for us, right? Really rethinking and reimagining health as not just something that's physical health, but your actual well-being. So that means we have to advancing birth equity by reducing global maternal mortality ratio, and also preventable deaths of newborns and children. So these are concrete steps that you all have already operationalized, making sure that we have universal access to sexual and reproductive health care services, including family planning, information, education. Next slide, please. So that leads us to how do we get there with birth equity? How do we think about those goals and then use this new frame around undoing racism, classism, and gender oppression to ensure that we have actual strategies, policies, culture shift to invest in all people for birth equity? Next slide, please. So you all know I hope, the Global Respectful Maternity Care Charter, through WHO, White Ribbon Alliance, and it was created with researchers and practitioners. When we researched this, not a lot of high-income countries actually use this language. In fact, we were hard-pressed to find any high-income countries that use this language. It's mostly in low-income countries, as if having wealth makes you magically respectful. So being a non-centered person in a wealthy nation, I can tell you, being wealthy does not make the folks here respectful. We die despite income, despite education. So how do we take this frame, this global conversation around respectful maternity care, and operationalize it in a high-income nation and a diverse nation like the United States? So the first thing was to see how this resonated with the people who are the most impacted. Next slide, please. So we interviewed Black birthing people across the United States to ask them, what does respectful maternity care mean to you? What would it look like to have respectful maternity care? What do you hear when you hear those words? How does that show up? How does disrespect show up? And what would that look like? Next slide, please. These are the themes that we heard from Black birthing people in the United States. They want accountability. They want equity. They want it to be invested in and not seen as throwaways. They want empathy. It seems so simple, but it's when you think about Lucy, Betsy, and Anarcha, you could see how empathy does not exist. They want safety. Once again, if you think about Lucy, Betsy, and Anarcha, you can see how that does not exist inside of our system for Black and brown and indigenous birthing bodies. And then racism, of course, they want us to undo our beliefs that we have thicker skin. We've interviewed medical students who said that they thought Black people had thicker skin, different nerve endings today. Like in 2019, these interviews were done. So this is still happening. There's studies that show that Black birthing people are less likely to get their pain treated after a C-section, a major abdominal surgery where you're opening up your abdomen, taking your uterus out, and we're still less likely to get narcotics afterwards. I guess we're just supposed to take a Tylenol and bite a bullet and keep it moving, right? So undoing the devaluation and the racism. And then this last one, this trust one, is so important because it's not something we talk about. Right now, you hear it constantly. Why don't Black people trust the healthcare system? Why don't brown people trust the healthcare system? Tuskegee, like it's a constant refrain. When are we going to trust the actual patients? What Black birthing people told us is they want to be trusted. They want you to say, I see you. I know you're doing the best you can. You value your family, your community. You might have missed some appointments, but I know you wanted to be here. That I know my body better than you do as a patient, even though I might have memorized as an OBGYN nerves and muscles and blood vessels, that I don't know a patient's body better than they do. I trust them. It's their body, their bodily autonomy. That's a totally different refrain from how we currently talk about trust in healthcare in the United States. It's very monodirectional. We just want the patients to trust us. Why don't they trust us? If we could show some bidirectional trust that we trust them, it comes a lot easier, right? It comes a lot easier. Right, next slide, please. This is the cycle to respectful care. It was published in a journal recently, an international journal. And so it's so exciting for us to really build out this framework, because people start with measuring and metrics, but they have no frame for what that even means. Why are they even measuring these things? So this is our really foundational framework for respectful maternity care in the US context. Next, we're gonna try it, test it with brown mommies, with indigenous mommies, to see how it resonates with them as well. But this is based on Black birthing people. And at the core is valuing Blackness, right? At the core is also your oath. Hippocratic oath. As a Black physician, we have an Imhotep oath. It could be your Nightingale oath. What holds you? What are you holding as your core? What do you value? Valuing Blackness is so important because it's honestly been devalued for hundreds of years. Like, this idea that we're broken just because of our skin color, just because of our melanin production, is inside of schools and textbooks, deep inside of theory today. I mean, I was taught that there were 3 races. This is in the late 1990s in medical school in the United States: Mongoloid, Caucasoid, and Negroid. This belief in a biological basis of race, and the devaluation and the hierarchy of which races have certain characteristics or not, just by our level of melanin production, is white supremacy embedded in our healthcare system. So we have to unlearn that and undo that. So the first step is waking up. And it might be that you watched the murder of George Floyd, or you heard about the murder of Breonna Taylor, or the endless list of others. Or it might be that your job or your work says, you know, we need to wake up. We looked at our data, and Black and brown and indigenous people are dying. We got to do better. So we got to get ready. So that starts with unlearning yourself, reading yourself, working on and unlearning the things that were taught that were harmful. And then you work with other people in your facility, and then you go out to the community. Often we're brought in as an organization to help people do some equity project. But if you haven't unlearn the harm that you currently have, you're going to go out in the community and harm them. So I refuse anymore to work with any organization that wants to go do some equity project that has not actually worked on themselves first. Because all you do is take your harmful selves out of the community and harm Black and brown people. And then I'm sitting there looking crazy. So first is getting ready, working on yourself first. Next slide, please. We worked on a telehealth project with some CARES Act funding, interviewed birthing people and Black birth workers around what telehealth was looking like during the pandemic. They really want quality and respectful care throughout pregnancy, even during a pandemic. Although there was social distancing restrictions, they wanted access to essential and wraparound perinatal services. And so telehealth could be an opportunity for that, to really still provide care. And honestly, we knew this before the pandemic. Having telehealth is an opportunity for decentered communities who don't have transportation, who don't have access, to really then still receive care. Now, the question is, what could that look like, and how can we not replicate harm when we build out this telehealth work as well? Next slide, please. So what we recommend after listening to Black birthing people and birth workers is you need to provide individuals with Wi-Fi. We don't have broadband across the United States. You also have to provide them with electronic devices and equipment to participate, right? So we're gonna have another gap as we build out telehealth, because we have not invested in people having access to these devices. Patients still want autonomy. If they wanna come in, they want the option to come in, that you can't just make everybody now go to telehealth, right? They wanna be able to decide when they wanna come in person, when they wanna stay at home. And you have to be able to integrate the telehealth into the current patient records and automate. So having a separate system for telehealth is also going to create a whole nother burden for patients and their ability to receive care. We have to educate providers. Some of the providers complained that they don't have dedicated time now that we have telehealth. Because, you know, you can make patients not bring their kids, not eat, drive and come to your office. When there's their house, you can't make Junior not come to and my son, he loves to come to the robot. Even when I'm doing a UN presentation, he doesn't care, right? So that none of that, there's no dedicated time. What the providers missed is that there's never been dedicated time. Even if we were alone in the room, we were thinking about our son that does the robot, right? So this idea that we could separate our lives out and only focus on you as a provider has always been deeply disrespectful. So really reimagining that relationship. You have to also, what the birth workers told us, is they need a livable wage. They need subscriptions to virtual platforms. They need telehealth tools. They need these fancy apps and all this other stuff. And you have to invest in Black birth workers and community-based women-led organizations. So it just can't be the hospital hires some women from the community and tells them to go out. Really, it should come from the community. That's where you're going to get the best outcomes. Next slide, please. Next slide, please, Katrina. Oh, and that's it. Thank y'all.
Thank you so much, Dr. Perry. That was so insightful. And I have a question, because you really talked about the importance of respect in maternity care. So we all have mothers, sisters, aunts, friends. What would be a good takeaway for people, they're pregnant, trying to become pregnant with their current medical provider? How can they obtain that respect in the current circumstances?
Yeah, I think one of the things, if you were to say to your provider, I've seen the data, Black birthing people are more likely to die. What do you think around that? And see their response, right? If they say, oh, don't worry about it, you should worry, right? So that they should be as worried as you are about the fact that they are at higher risk. And they should also not articulate this in a way that blames and shames you, but they should understand that the hospital and the system that they work within is deeply problematic, and that they're working really hard to ensure that you are safe, that you are heard, and you are valued. So I would just start with some basic questions and trust building with your provider. And if they don't give you the right answers, switch. You have the power to switch. We found so often many patients don't change doctors. We feel some kind of sense of loyalty, like we got to stay with them. No, you don't. Sis, you can leave. It's really not, just you can find another doctor. So I know that's easier said than done, but I think just knowing that you can empowers you in a very different way. Very different way.
Thank you so much.
One more question
Yeah.
from Victoria. For people who want to start an advocacy drumbeat in their own community, what do you think is the first fundamental step that they should focus on? And how can they keep educating themselves as non-data experts?
Yeah. So I started off, as a practicing OBGYN. I was not an advocate. I was just trying to see patients. And I tied myself to other organizations, and I learned about advocacy from other organizations. So I was able to work in city government, work with other nonprofits. So I think even if their issue is not yours, so like if you want to start an advocacy organization on birth equity, but everybody around you is working on climate change, you can learn advocacy from them, working with them, and then give the lens around birth equity and adding that. Because we also recognize all of our issues are so tied, right? So like the climate issue is a birth equity issue. So if there's a person in your community or a group in your community who's working on criminal justice reform, that's also a birth equity issue. So working with them and then carving out your lane around repro, around birth equity, allows you to learn while you're with them, but also building out a strategy for birth equity.
Yeah, and I'd also say, I think there's opportunities to work where you are, right? So whether that's in your college campus, in your church, they're again, aligning yourself with organizations who do this work, I think is key, but then taking that and creating your own advocacy, right? And your own advocacy groups within your circle that you're aligned with, I think will help us to even spread this even further.
Wonderful. And then I have a question for both of you. So what do you feel is the largest challenge in advocating for legislation that would move us towards birth equity?
When the problem is our default around the globe, not just the United States, our default is white supremacy culture, right? So that's like, we don't even think about it. It is baked in how people respond. So I'll give a concrete answer. When I ask around something that I think is simple, like childcare, we should have universal childcare. That seems like a simple birth equity request. Like we pay way too much money for childcare. The response you'll get from legislators, from lawmakers when you testify in front of Congress is, well, I feel like that makes my son get off the hook for having to take care of his family. That childcare should be a family's responsibility, right? So the default of the belief, so you have to first understand what white supremacy culture is, right? So this idea of heteronormative, two-family household, husband, wife, the husband and wife stays home, like all of that is baked into our policy. So the policy makers then want to make policy based upon that belief. So their struggle right now is that all of us are coming in saying, we don't want white supremacy culture anymore. We want And I mean white folk, everybody. We're like, no, this is not good. We all working, we need childcare. That shouldn't be controversial, right? So that really, the tension of moving away from the kind of normalized, embedded white supremacy culture to one of multiculturalism, of seeing indigenous practices as important, of seeing women as important. Like all of that is just hard for the legislators who currently look still like old white men to really hold on to. That's been their frame. Giving up that power and seeing themselves as tied to these policies is really hard. So I told the last time I testified, for the first time, because normally when you're testifying, you can see kind of which side people are on. This on Zoom, you don't know. So I used my little social cues of assumptions around who was going to say what I couldn't do. And I realized how deeply racialized even the policies are and how deeply racialized this agenda is. And so for us to get to the other side, we're going to have to really be honest about that and make some changes for equity. And now the last thing I'll say is one of the policymakers who, when I was testifying, who was a leading liberal Democrat person said, well, we can't legislate anti-racism. And so that belief, that idea that racism is not something that's baked in policy, but more is like individual choice of behavior or people's taste, that is a big barrier. Because if you can't see as a congressperson who's an ally that the policies are racist and your job is to undo the racist policies, we got a lot of work to do. So it's not just the folks who are fighting us, but our own allies think of racism as like a personal choice, taste, versus structural and embedded in policy and baked in there and what they do every day.
Yeah, and the only other thing I'd add to Joia, 100% with what she said, is that, folks who are also at the seat determining the policies don't look like a lot of people that they determine the policies for, right? And so again, that's where you get that structural racism, patriarchy, because you're not including at those seats of power and decision making and policy the people that you're wanting to most impact. And so I think that's something that we continue to have to fight for, and we shouldn't be fighting for it, but we do, to make sure that policies that are enacted are the appropriate policies for the populations that we're wanting to serve.
Definitely.
Wonderful. Thank you so much to both Dr. Perry and Dr. Seeley. This was absolutely amazing, and again, a very essential conversation to have. And I will now turn it to Nikita.
Thank you again for those excellent presentations and leading this discussion. I know I've learned a lot, as well as most of the attendees here. We really appreciate it. And moving forward, don't forget to all the attendees to join for our free week of action on June 6th to 11th to learn more about advocacy and participate in virtual meetings with your member of Congress's office. And you can register at this link. And Power to Decide and NBC are both great resources to read more about birth equity. So be sure to check out their websites and learn more about what work they're doing. Thank you all so much for attending. We really appreciate it.
Thank you.
Thank you very much.
Bye-bye. Thank you all.
Goodbye and thank you.